So it is week 5. It's going by very quick. Exam 1's done. Next week, we're starting already reviews for exam 2. And if you're going to look at your announcements, it's already posted. So you will see them coming up. They're all through the week and on the weekend. So all different times of the day. So hopefully you'll be able to catch one. But of course, it will be placed on the announcements. On one announcement, I'll keep refreshing it, renewing it, and putting in the new recordings. So you don't have 7 different announcements from all of us. I think that's really ridiculous to try which one do I want to look and where announcement is it. So I try to keep you organized with one. Do you notice I put your Kahoots in one place, you have your study guide one place, and you'll have all of your recordings all in one place. So just, look at it, refresh it. After a recording has been done, one has already been done, you'll see it. This is a great week to start your pediatric assessment project. This week, you don't have an exam. Next week, it's not heavy on homework. There is a discussion question, also a CJ Sims, but you can at least start the beginning. Remember, send me the topic you want to do. And as I was discussing earlier, pick something near and dear to you, something that you, your child, your mother, your uncle, your friend has something and you want to know more about. And it makes the project more of producing work than understanding something you're interested in. Try to at least do the 250-word APA paper. If you send it in early, I will correct it, send it back so that you can get the highest grade you can. If we look at it in concept, all your CJ Sims are equal to this one assignment. It is 3 parts. It's the paper, it's the assessment form, and then teach me something. If it's something about asthma, teach me what you do, medications. What do you do with an asthma attack? How to use the little inhalers or the aerosol. Give me teaching, something you teach either a nurse who maybe doesn't know about the diagnosis, teach a mother, or teach a child, or both, okay? So send in your what you want, and I'll approve most of them as long as I don't get 10 asthmas or 10 ADHDs. Try to make it, if you can, mix it up. Give me some different ones. I like it when a student picks something different and new, and then I can learn myself. Yes, I know a lot about everything, but I don't know everything, and I learn every single quarter that we do this. Some student will send me something I have not learned about yet. So last week I wasn't here. I was in Disney. I had a great weekend with my family. It was a lot of fun. In fact, during class, I think I was making a big pan of lasagna for the family. And actually, I made 3 big pans. It was a 12-bedroom house with 30 people. So I was cooking, 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 cooking. So it was a lot of fun. I did give you extra recordings. I sent the recordings of the professor who did it, Professor Morris. So thank her. She teaches different than me. It doesn't make it one better than the other. It's just different. Um, and this week, if you noticed, check your announcement. I have put a matching sheet, cardiac respiratory matching. It is every concept, every topic you might see, and you match it up, with what does it mean, okay? So it gives you that, all right, I need to know these. Also, I did attach a cardiac worksheet, much like Professor Morse does. So whatever you like to do. I've given you all options on how to study. They're there. And then, of course, you do have the Kahoots. Any questions? All right, let's go ahead and get started. So we're going to start out with respiratory. If you can't breathe, nothing else matters, right? So when we talk of upper respiratory, and we talk lower respiratory, they actually make a difference in children because children are always mucus in their upper airway. They don't like to blow their noses. It collects there. We know that ear infections are big because of all the short, straight structures. And we know that sounds in the lungs could actually be referred from all the upper airway stuff. So knowing how to listen to the bronchial airway and then or the vesicular, the low one, makes a big difference in children. Now, in children, most upper respiratories are viruses. One of the ones we hear about a lot is something called respiratory syncytial virus, RSV. Now, usually after 1 year of age, and I'll say even 6 months of age, it's really a common cold. As you get older, you can see the difference in symptoms. So me and you, it's a common cold, but for a newborn infant, a young baby, it's hard because they're obligatory nose breathers. Now you put mucus in there, and what is their job? To suck, swallow, and breathe. So it becomes all of this extra stuff, and it really, you'll see a lot of respiratory problems with it. This could be a big problem if you were premature or if you have any underlying condition, cystic fibrosis, um, or if you have a cardiac condition, right? These things, and then an extra work to breathe could be too much for them. So we do give preventative immunizations. Now, this is a different immunization. It's only for the first year of life, and it's from early winter to spring, and it's monthly, and it's called Synagis or Pavizumab. It's a biologic, and it's once a month, and you have to get special approval, insurance, and all that good stuff, but it works. And these children don't get that upper respiratory RSV because that little fever, that mucus, they get irritable, they don't eat. And guess what? They don't eat. Cognitively, they're going to be delayed, and it could create that other problem, like cardiac problem. They can go into failure and whatnot. So, upper respiratories can be dangerous in the young ones. Now, talking about infants and talking about how they're born. Now, we know they're born with mom's antibodies and mom's blood, mom's red blood cells. And we'll get into that more next week when we talk more, about blood and those things that we're going to go on there. But when your baby's born, we know that we have maternal antibodies. And usually, if we are pretty clean with that infant, usually they're not going to be sick. As they get older, mom's antibodies go away. We know the blood cells die. They don't make blood cells yet, so they become more anemic. So what happens? They get sicker. So that 3 to 6 months is when we start to see them getting sick. As they get older, toddlers, what did I tell you they do in daycare or when they're with other kids? They swap spit all day long, right? This toy to this kid, and they pass it around. And you're like, but what can they do? Well, it's actually not a bad thing because by the time they get to school, they've already been exposed. Their body's already made all these antibodies, and now they're not going to get as sick. So I've heard parents say, every week I'm here in the ER since they started daycare. And I'm like, yes, they're swapping spit all day long. And even if they did clean those things down in between, there's still going to be something happening there. You can't prevent it all. As they get older, we know they've been exposed. We've been given all of those immunizations. We start at 2 months, 4 months, 6 months, 12 months, 15 months, 18 months, 24 months. We're giving all of these immunizations to give all those antibodies for that child to ward off all the really bad sort of diseases. As they get older, it's more bacterial, like in strep, strep throat type thing. Big thing that happens in kids is ear infections, right? Why? Well, they've got these short, straight, open tubes at the back of their throat. And guess what? Mucus goes to the areas of least resistance, and that's up those tubes. and put all that mucus in the inner ear. Now you have pain. Now, the first thing as a nurse, what do we need to do? Have you ever had an ear infection? They hurt. Medicate for pain, that's your priority. Because antibiotics aren't going to kick in for how long? A day, or two? But the pain we need to relieve right away. So we're going to be giving ibuprofen, acetaminophen. Acetaminophen works just well. Remember, young kids younger than 6 months do not get ibuprofen. You have to be 6 months old for it, and it has something to do with blood coagulopathies. Because remember, NSAIDs can cause bleeding. So remember, we don't give it under 6 months. Then after 6 months, we can alternate ibuprofen and acetaminophen. One of the most common surgeries is what in children? Tubes, right? Tubes, tonsils, adenoids. I mean, that usually all goes all together. So, and that would be that child who's having chronic ear infections. One of the things we teach these parents is to make sure, and it's one of the big things that causes ear infection, is smoke, that secondhand smoke in the house. So anybody who smokes, get out of the house. Leave the kid alone. As I said, they're open. Now, what does a kid look like when they're getting sick? Well, I think the first thing you'll see is a kid all of a sudden is quiet, sitting in the corner, and doesn't want to eat their favorite food. And you feel them, oh, and they have a little bit of a fever. Once that happens, you take your temperature, you get your fever, and they're not eating. What do we need to do? Well, you might see them vomiting or diarrhea. Their tummies might hurt a little bit. You might see a cough. You might see nasal mucus. Or you might hear that bronchi or something going on, or that upper respiratory sort of things. One of the things we need to do is decrease that fever. Now, we treat these things by, if you get the fever down, the kid feels better. The kid feels better. They're going all of a sudden in 30 minutes, they're up and running around, almost normal, and they'll eat and drink. And our goal is to get them drinking, right? Getting that fluids, replacing that insensible water loss from those fevers. We also, they'll rest easier. They're in pain, medicate for pain, they'll rest easier. And that's what we want to do, promote that comfort. Also, I think today more than ever since COVID, children know how to cough into their arms, right? They know not just to cough out in the air. When I was a kid, they didn't do those things. They didn't understand it as much, but today they do. And washing hands is a big thing now, and those alcohol wipes, et cetera, et cetera. So these kids get their fever down and start their antibiotics, and they'll do okay. Now, infectious mononucleosis is the kissing disease, right? We've all heard of it. It's by sharing, sodas and whatnot and straws. And or they kissing, they say. It is a herpes-like Epstein-Barr virus. So again, word virus. So if it's a virus, it's not antibiotics that's going to treat this, right? Well, we think, okay, virus, give them Tylenol, give them their ibuprofen, fluids, and rest, and they'll feel better. Sometimes that works, and it was just a little pharyngitis, viral pharyngitis, but sometimes the sore throat, the fever, the aches and pains, all of it continues. So they go back to the doctor. And after everything's negative, strep's negative, culture's negative, they'll say, well, I don't know, so let's put you on antibiotics. Of course, the antibiotics aren't going to do anything. That's usually about a week later, I'll see them in the ER where I worked for the last 10 years. They'll come in and they'll have a sore throat. We've done this, and that, and we'll draw bloods. Well, of course, we'll do a CBC. What would I be looking for in a CBC? Well, that's the white count, right? Because bacteria will have an elevated white count. A virus will not. So if it's elevated white count, we know we're working with something that needs antibiotic. Now, the other thing we do is we test what we call a monospot test, and it looks for mononucleosis. Most of the time, these scenarios where they've had a sore throat, fevers, aches, and pains, they've been on antibiotics, then they come to me, well, that monospot test's positive. What is the big deal about mono? Well, you're going to see liver and spleen will get all swollen. That spleen could look like a big basketball or a balloon. And if it's hit hard, it will burst, which means your spleen bursts in your inside abdomen. What's going to happen? That child's going to die. I'm going to give you a story. 9-year-old boy comes in my ER one Saturday morning with his father. All that stuff I just said happened, monospot positive. The doctor was an excellent physician, told him, please, no contact sports, no PE until you go back and check with his pediatrician. We explained about the spleen and the liver could be swollen and his tummy was tender, blah, blah, blah. Well, on discharge, I did the same thing. 1 week later, I am now primary trauma nurse, which means anything that walks in the door comes on a helicopter. I'm the nurse that arranges everything and I run the scenario, okay? Well, we get a call. Kid, 9-year-old boy on an ATV in the Everglades fell off and he came in dead on arrival. His spleen had burst. He fell off on his abdomen onto a rock. Now, I'll never forget that story. I'll never forget that boy. And it's something that could have been prevented. So, what do you need to remember? Have a kid, positive mono, make sure you teach them, protect that abdomen. No contact sports, no PE until they're checked by their pediatrician. Now, bronchitis is something I think we've all had. That's that I'm coughing all night long. You may or may not have a fever, but you're coughing. It's dry. Nothing's coming up. And the cough just keeps coming. You can't sleep. So you go to the doctor and they're going to give you some cough medicine. Hopefully, it's something with codeine that's going to stop it, right? That actually does help. Now, we also probably on these because they don't know exactly inflammation bronchitis. Usually that's your Z-Pack. But this is a dry, hacking, non-productive cough, and it worsens at night. And bronchitis is just symptomatic. If you have a little fever or your ache and pain from coughing, acetaminophen, ibuprofen, and cough medicine suppress that cough. And yes, humidity does help. Now, croup. Croup is that cough that you get that sounds like a seal barking. You can hear it from across the grocery store if a kid is barking or even adult barking. You can hear it. It's distinctive. And what it is the upper airway around the epiglottis is starting to swell. What it causes is you can't get air in well. You can get it out because the lungs are fine. They're not irritated, they're not inflamed. It's only the upper airway. So they'll have this barking, barking, barking cough, and they'll have what we call inspiratory stridor because it's swollen. So the opening to get air in is more narrow. That's why there's inspiratory stridor. This is important because there's something else that it's all about expiratory stridor. If we do not treat croup, that swelling will continue. And how do we treat croup? Usually it's viral, and all we do is give a steroid, whether a 1 IM injection, 1 PO dose, or several. And all doctors use different stuff, but it's a steroid. Sometimes we'll even use racemic epi in the ER to get it, calmed down. Laryngeal bronchitis, again, that's your croup. And this is what we'll hear. And as I said, if we don't take care of it, it's going to lead on to some life-threatening stuff. The swelling is gone up, air can't get in, and you end up with acute epiglottitis. Now, I've already said that back of that throat swelling around the epiglottis. What does that epiglottis do? That's that leaf-like structure that covers the trachea when you swallow so that food don't go in your lungs. Well, that's the airway. It's now covered by this swollen epiglottis. and you can't get air in. So again, inspiratory stridor. You can't swallow. You're becoming hypoxic. You don't cough. It is agitation, hypoxic, right? Drooling because you can't swallow that and you're not coughing. If they were to talk, and we're not doing this because they so you hear me? You can't be garbled, frog-like. You wouldn't hear it. This is that old tripod sitting, trying to find a place where you put your throat where air can get in and get, breathe, okay? What is our job with this? Well, number one, try to calm that child down. They want to sit on mom's lap. They don't want to get on the stretcher. They want to sit in a chair. I don't care where they go, as long as I hook them up to the monitor and then we'll start our treatment. And one of the things I'll be yelling for my care assistant, please go get me an endotracheal tube tray and get me a tracheostomy tray. Right now at bedside, there could be an emergency intubation or tracheostomy done there. So what is our goal when this happens? Well, we got to get the airway open. That's that racemic epi. We think of epi and anaphylaxis and injection in the arm, right? Well, this is racemic epi. It's an itsy bitsy amount, but it aerosolizes and it goes directly back to where it's all swollen and it will open it up. Do you know in all my career, I've never had to intubate a child because of this or a trach, and I've seen a few. So this help. Also, we're going to give moistured oxygen. Usually it's a face mask that even a parent could just hold it there where it's getting that moisture and oxygen at that child. And of course, steroids. Usually this kid's not going to have anything by mouth. So we'll start an IV and we'll give fluids that way. And of course, we're going to be giving steroids. Again, decrease the swelling, decrease the inflammation. So RSV, like I've already told you, it is winter, early spring, and the prevention is that Synagist once a month. Palvizumab is a biologic name, and again, it's given to those children who are more apt to have problems, like the child who was premature or still on oxygen, or a cardiac child, or cystic fibrosis, some child that needs it. Now, we talked about ears. One of the major surgeries, well, so is tonsils. Usually, tonsillectomy children come in through outpatient, go into OR, and they're sent home. Sometimes you might see them go to the floor, but if you ever work in one of those perioperative areas, we need to know what to teach these parents. Now, when they're waking up, we have them laying on their side because they might bleed. If you think about tonsils and how they do the surgery, those are those big things that stick out from the side of your throat. And they literally take a scalpel and cut them off and cauterize those area. So it's like a big scab. Can you imagine? It's tender and it can bleed if we're not careful with it. So that being said, no irritating or highly seasoned food. You wouldn't give orange juice to this child. That would burn, right? Or you wouldn't give anything with hot sauce or spicy, too spicy. You're not going to gargle. Can you imagine gargling? One of those scabs will come off and you will bleed. And I've seen children bleed clots after a week after surgery of tonsils. You're not going to put anything in the mouth, just like epiglottitis, tonsillectomies, no tongue depressors, nothing in the mouth to inspect the oropharynx. It will just increase the swelling or start them to bleed, okay? This is an important concept there. Now, one of the things that we do for care is we just give them acetaminophen, and it works. Years ago, we gave them a hydrocodone, but we found out kids were overdosing on it because they've never had it before. And they're going home on this liquid medicine. And, parents are like, well, it'll hurt. We'll just give them more. Well, more is not always better, right? Keep them quiet so that they don't bleed. And the older kids will take the ice pack and put it on their neck. And chewing gum, because look, those eustachian tubes are at the back of the throat, right? And there's swelling that's gone on there. And the ears can feel full. So they chew gum, just like going up in an airplane, chewing gum so that their ears pop. And it will decrease that pain. If they start with fevers later on, I mean, the first day or two you might. It's just part of the body's response. But 5 to 7 days post-op, they shouldn't. So if they have a fever and that mouth smells, something's going on. They usually are back to regular activity a week or two after their post-op check. Now, pneumonias are interesting. Could be caused by a couple different things. It could be due to that good old baby powder, right? That we have in the air. And that aspiration. It could also, if you think about it, the way that we feed them. There's some kids who do have that reflux and they do spit up with every feed. Now, spitting up, you have the possibility of aspiration. So teaching them, parents, how to feed their child properly, not to overfeed, how to burp well, sitting them up after they eat. All of those things are going to help decrease the incidence of aspiration pneumonia. And of course, no caustic, type of chemicals around them. I mean, have you ever gone in and cleaned your bathroom with bleach or some things and it's so caustic that even you feel tight in your throat? Well, we don't want that on the kid. So, foreign body aspiration. You talk about children and you think that they would, if they're going to pick a coin, they're going to pick the dime or the penny. I've never seen a dime or a penny. It's always a quarter. Now, last semester, I was teaching this. And when I was teaching this, my second oldest grandson was in the OR getting a quarter removed from his stomach. It actually had caught in the bottom of his esophagus and didn't come up. And he had it in his mouth, a 9-year-old. Now, usually they're a lot younger. Now, that's one way of treating it. I've seen it treated that come in where it looks like that x-ray picture sitting right there. And what they did was they'll take the surgeon, put the child on the surgeon's lap, of course, mom and dad there holding the hand, and they take a Foley catheter, put it down below the quarter, blow up that Foley catheter balloon, sit them forward, pull it out, and they'll vomit and the coin will come right up. Now, what did I do to keep these kids calm? I said, when he pulls that out, you're going to spit a little bit up and the quarter's coming, and I'm going to beat you to it. If I get it first, it's mine. So they immediately, after they spit up, would go to the floor to get that quarter. They would not even be thinking about what just happened. And then we'd watch them for a little bit, making sure the area was good, and send them home. I've seen children aspirate a French fry. One little 3-year-old boy, it was a French fry, got stuck in his trachea. We couldn't get it out. He ended up on ECMO and actually 3 days later died. So there's all different outcomes to this. So making sure that we keep small objects away from the young kids. Now, pertussis, why am I mentioning this? Well, a couple years back, they started having more outbreaks of pertussis. And I know it came to our ER and the next county up. And we were like, why? Well, there are some people who don't believe in immunizations. I mean, it's their right, but if a kid gets pertussis and goes into the ER because they have this cough, fever, and they're sick, well, they are airborne and they're highly, highly, highly contagious. And there is a vaccine for it, right? We should be giving it that 2, 4, 6 months. Now, pertussis is all respiratory. They have to be put into a airflow room where the air in the room goes outside, so that the whole hospital's not breathing it. And as a nurse, have yourself with a mask on, the N95, absolutely, because it is dangerous. And they treat it with azithromax. Smoke inhalation happens for many different reasons. Fires, it could be, the bonfires outside. I live in Homestead and it's country down here in many areas. And they have big bonfires, barbecues, things catch on fire, whatever. Getting that in can be a big deal. Again, it's giving 100% oxygen, monitoring that airway. Cystic fibrosis, one of those respiratory diseases. Sometimes we know they're going to have cystic fibrosis. Today there's all these different tests they do for pregnant women. But one of the symptoms that you would see for a person that we did not expect or didn't know or didn't have those tests, when the mother was pregnant, this child will not move their bowels. They'll have a meconium ileus, it's what it's called, in the first day or two of life. There are 3 things that it could be. Cystic fibrosis is one. You also might see Hirschsprung's disease. We'll get to that later. That's an obstruction. And it could be hypothyroidism. So when we see a child not stooling, and we know a kid comes out and they're stooling usually right away, right? Well, they're not. We'll test them. And what we do is what we call a sweat test. And it's literally monitoring salt on the skin. These children, if you were to tell the mother to lick their skin of their baby, it would be very, very salty. Because of that, these children, you're never going to limit salt intake on them. They need salt. They're losing it like crazy. Cystic fibrosis is a condition of mucus that fills up the lungs. So you're going to be with aggressive pulmonary care. And you're also going to have problems with digestion in the small intestines. Fat is not being broken down into a manner where the body can handle it. So these children will be on medications before every meal, before every snack, and it's going to try to help this child digest. Now, fat is the highest calorie nutrient we have. So we have to replace it, right? So high protein, high calorie diet, salt, give me salt, lots of salt, okay? Those things will be done. Now, this pancreatase doesn't take all of the fat in. So fat will be in the stools. It will be foul smelling, greasy, and bulky. And these children, we have to monitor their height and weight really closely because they are getting less calories because of that no fat, really hardly any fat getting in. So pancreatic medicines. So all of those chest CPTs we're going to give. We'll give aerosols with antibiotics. Remember, when you're going to be doing cystic fibrosis, those chest problems, if we're going to be doing treatments, and we're going to be doing 3, 4 times a day, depending, do those bronchodilators, chest CPT, before you eat. Or guess what? They're going to vomit. And we don't want them to vomit. So we're about ready to eat immediately before, whether it's a snack, whether it is a meal, you're going to use these pancreatic medicines. Pancreatase is one that's used frequently. Some of them come in little capsules and beads. Some are powders. This is the one that you can, when we talk about giving medications, we'll put in the food. Now, other ones we don't. This one we do. So if the enteric little beads are there, again, we're not going to crush them or chew them. They have to go down the hole. If it's capsules, sprinkle it there. And if it's powder, it's just like some of those aerosols where you have to rinse your mouth when you're done so that your teeth, that calcium is not broken down. Make sure we rinse it. And the other thing that we need to know about giving these meds is as they grow, they need bigger doses. I think in all areas that we have a chronic condition requiring medicines, as a child, these kids are growing, and I don't think we keep up with it quick enough. Sometimes you have breakthrough seizures because they don't have their seizure medicine. Now, with this one, they're not going to be getting their nutrition, so you're going to see a decline in weight. So we're going to give that airway problem things. We're going to do bronchodilators, good physical exercise. I'm going to recommend swimming almost for everything because there's no allergens. It's holding their breath. Most of the children, and kids like to do it. And a lot of times we're going to be giving a lot of medicines in the aerosols. I think gentamicin, tobramycin are some of the big ones that just in a little aerosol goes right into the lungs. And of course, pick lines with IV antibiotics because they're always with lung infections. So like I said, pancreatic enzymes, we know how to give them now. It's important to know that. The diet, you need to know that. High protein, high calorie, and it's going to be low fat because they're not going to tolerate it. And then we're going to, if they're young, making sure that they're stooling and sometimes because of all of this medicine, reflux. So be watching it. Now, as I said, cystic fibrosis has to do with pancreatic insufficiency. What does the pancreas do? It produces insulin and it prevents diabetes, right? We will be doing spot check glucoses on these children to make sure that their pancreas is still functioning, okay? One of the things as a cystic fibrotic child grows is they're awake, they're alert, they're normal kids. It just means their lungs and their small intestines isn't working the way it should. Now, women can get pregnant. Yes, they're high at risk. They can get pregnant. Men, something to do with their vas deferens, gets mucus and it clogs, and they're unable to get a woman pregnant unless they do a bilateral lung transplant. And 1 year later, they can have children. So that's the big thing about pregnancy and cystic. Sleep apnea, I think many people of you all have it. Kids, just because they're kids doesn't mean they don't. Again, sleep apnea and they're not getting enough sleep. Not getting enough sleep. They're cranky during the day. They want to sleep during the day. So again, finding out, are they having apnea, doing whether tonsils, adenoidectomies, that machine that older people wear, well, they're going to do it too in order to get the sleep that they need. So it's having parents and children understanding it so that they can get the help they need. ARDS, acute respiratory distress syndrome, something happened to the lung, whether it's a physical injury or whether it's infection. Remember, one of the biggest problems in children is overwhelming infection and sepsis, and it leads to multi-organ failure. So sepsis is huge here with the lungs because it will go in there. As they get older, it could be drug overdoses, and any kid who has a near drowning episode has had a hypoxic, anoxic episode because the lungs are filled with water and the lungs are angry. And a lot of times, this angry of drowning will show up 3 days later. These children, for the first 2 days, look fine, wonder why they're in the hospital, and on the third day could go into respiratory arrest because that's when their lungs up to 72 hours later. These kids are sick. That's the machine that's ECMO, believe it or not. All of that blood and machines there. And all it does, it pulls out blood, it oxygenates it and puts it back in. It's not like a heart-lung machine. It's only oxygenation. A lot of newborns with meconium aspirates, when you have diaphragmatic hernias or really bad lungs at birth, they'll be placed on that for several days to let the lungs rest and get the oxygen to the child. These kids are sick, really sick. And if they make it, we've done okay. Always look at your CPR, understand it, know what you need to do. Many of these exams have it on it, even your HESIs and NCLEX. So that's why we renew that CPR card. But in the hospital, remember that there's a parent whose child is coding and make sure somebody's with them. You know, it used to be the parents weren't allowed at bedside at a code. Today, we want them there. Why? Well, what if that child dies? They weren't there when they died. So always, always include the parent into it. Always have somebody only with the parent holding their hand, telling them what's going on and keeping them okay. All right. Very important. Now, asthma. Many of you, many of your children, you know somebody who has asthma, right? What is it? Well, it's a hyperresponsiveness in the lungs. So once we figure out that this happens, it's periodic, we're going to be doing pulmonary functions. We're going to find out what are they allergic to. You know, if they're allergic to grass, these children shouldn't be out playing soccer or baseball, right? There needs to be another sport for them. And we could do that or desensitize them to their allergens. They need to be up and out and moving and doing what they need to do, but they need their little rescue albuterols, right? Their little inhalers to bring with them. Asthma. It's a starts with a coughing, and then you're going to hear wheezing like crazy. And asthma is lower. Those airways are swollen, and this is the expiratory wheeze. Remember I said croup, inspiratory, epiglottis, inspiratory. Well, asthma, it's the low lungs are swollen. They can't get the air out. So we treat them with, just like we do adults, we give like Symbicort or Advair morning and night. Well, children is something called Pulmicort. And we give that preventative morning and night. Then they have their rescue. Of course, the steroids as they need it. And then children, the young ones who are used to it, will use their own little spacer and give it to themselves. And because they get used to it. I mean, when they first start it, they're going to cry. But you know something? When they cry, they take a deep breath in and they get all the medicine in their lungs. What happens if you go into an asthma attack and it doesn't stop? My husband had one for 12 days straight. It was very frightening. It is where, you know, you're not breathing well, and then it gets worse and worse and worse. And what needed to be done was just an introduction of many different things, you know, a BiPAP machine to try to help them breathe. It was theophylline, steroids, aerosols, you know, and trying to turn it around. After 12 days, he walked out. He never got fully intubated because I was at the bedside. And he could look at me and I could calm him down. Again, with children, keep them calm. You know, COVID again is all upper respiratory. Again, trying to get those immunizations can help. And that's the newest thing that was on the respiratory. Okay, heart. What do we need to know about the heart? Well, children are different than adults in a heart. Children don't have myocardial infarctions per se, maybe one rare one, but usually it's congenital or an acquired condition. Congenital, it's they're born with it. And I'm going to go over some of the ones that you need to know. Acquired could be usually, believe it or not, it's an infection and it's usually viral and it attacks the muscle of the heart, causing myocardial infarction, cardiomyopathies, which is stretching in a big heart, means it's not beating the way it should. It could be due to something in the environment, and sometimes familiar. All right, I'm going to go into a diagnosis that you need to understand called coarctation of the aorta. Now, if you don't know the things of the heart, let me quick go through the way blood goes through the heart, all right? To go over those valves and where blood flows. So we know blood comes back in through the inferior and superior vena cava, and it just gets back to that right side, into the right atrium. There's a valve that's in between the right atrium and right ventricle called the tricuspid valve. Then the blood goes up through the pulmonary valve into the lungs, back through the pulmonary vein into the left atrium, through the mitral valve into the left ventricle, up the aorta, up the aortic arch, and down and to the body. Well, those little three things, those little red ones on top of the heart, those things are up to the upper extremities and the internal, external carotids, subclavians, all of those going up. The arch going down, usually right after those three vessels, it gets kinked or it's narrowed and blood can't flow down. So that left ventricle is beating and it's trying to get it down, and only part of it gets to go down into the organs and down into the feet. What would I see as a nurse? How would I know that? Well, if you have decreased blood flow going to the lower extremities, you're going to have absent or minimal pulses in the feet, dorsalis pedis, posterior tibial. Blood pressures are going to be lower. Those are two things, right? Blood can't go. Now, what happens to the blood that can't go? It's going to go somewhere, right? It has to. So it's going to go up into the head and it's going to go back into the heart, into the left ventricles, stretching it, going to left atrium, stretching it, going back into the lungs, and the lungs fill up with the blood. Okay? Now, what would you see? What would this kid look like? This kid is now full of fluid, heart's not working right, the body organs aren't getting all the blood that they should. These kids are going to tire out easily, poor feeding, because of the fluid, they're tachypnic, tachycardic, they're not gaining weight because they're not eating, no activity at all. They can barely even finish their bottles or their breast because they're not getting food. You're going to see developmental delays. A great, great nursing diagnosis for this sort of child. Inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed. Most congenital heart defects will not be normal weight. They'll be less than, because the heart is beating up all the calories, trying to work. So when you get a kid, what do you look at? Well, height, weight, color. Let's see. I can take my hand and put it on a chest on some kids with murmurs, and you can feel buzzing without even a stethoscope. You feel those murmurs, whether it's a ventricular septal defect, whether it's, and we'll go further, to a patent ductus arteriosus. You can actually feel them, but you can hear them too. That's why we listen to them. You know, clubbing doesn't happen till later on. When we take these children, we'll connect them to a heart monitor. Usually, yes, their heart rate's going to be a little higher, trying to get blood around. Heart's trying to do what it's supposed to do. Yes, they'll be tachypnic because, again, they're trying to get oxygen around. We're going to be looking at all those pulses, right? Now, if I have low pulses and, in the lower extremities, those blood pressures are going to be lower. To reconfirm that that's coarctation, do the four extremity blood pressures, do the upper extremities. you will see them at least 20 millimeters of mercury higher in the upper than the lower. And that's your definitive tail. I caught one in my career, so I was pretty happy with it. We're going to be doing, of course, 12 lead EKG. We're going to do an echocardiogram. And if that echocardiogram shows anything going on, we're going to be doing a cardiac cath. Cardiac cath goes in and we can find out everything that's going on. Now, these kids usually are not held NPOs by midnight. No, especially newborns. Sometimes we'll feed them up to 2 hours prior to procedures, especially like breast milk. Absolutely, because it goes away very quickly and we want to maintain blood glucose, right? So when they come back, we're going to be checking, of course, that blood glucose because we don't know if they've been given any sugar or been given too much. But the first thing you want to check is the dressing. Now, where is this dressing? In the right groin is your right femoral artery and your right femoral vein. 2 catheters are put in. When they're done doing everything, they pull them out and they hold them until they stop bleeding. When they see it stops bleeding, they put on a pressure dressing. Now, they're rolled down the hallway, put into bed, they're jostled, right? So the clot that was on these areas that had stopped bleeding, possibility it's now bleeding. Can you imagine a newborn infant in these big vessels? All of a sudden, that clot comes off, they'll bleed out quickly. What do you do first? What do you do if that is bleeding? Well, you're on an infant. You take 2 fingers above the dressing where you know the femoral artery is and apply pressure and call for help. Immediately you want to stop that blood because that's the treatment. And then the doctor can come and look and see how much blood came out and if there's anything else. But your biggest risk in these children is hemorrhage. You need to keep that right leg straight for 24 hours. They need to be on bed rest 24 hours. Slowly raise the head of their bed. And they can have IV or PO depending on what they're looking for, okay? And of course, vital signs, checking pulses. And you're going to have some decreased pulses, but just document and pass it on and report exactly what you're feeling, okay? And of course, again, do that blood glucose. Down's children, they're very specific. There's actually 3 conditions that they're very prevalent. Congenital heart defects, leukemia, and thyroid disease. Those are actually 3 things that these children, that you'll see more of them in this group of children. So knowing that, and a Down's child is born, we're going to be checking that heart. And that ventricular septal defect is number 1. There are other ones, AV canal, truncus, whatever those mean. It just means the heart's not done right and it needs repair. But these children do actually very, very well. Now, do you know what a ventricular septal defect is? We have 2 ventricles. We have a right and a left side. And there's a piece of tissue in between. That's called a septum or a septal. And there's a hole in it, which means blood is flowing back from the left side back to the right side. And whenever you have a hole between that, it will always go from the big flow of the left side back into the right side. So we know that blood's going to go back to the lungs. Go back to the right side. Where does it go? Back to the pulmonary valve up into the lungs. So these are things that we need to know. These children are totally oxygenated. It's not that they're lack of oxygen. So there is the acyanotic, which means they have oxygen, right? That's one of them. Cyanotic could be your tetralogy of flow when it's in a tet spell. And the hypoplastic left heart. tricuspid atresia. There's a bunch of them, but there's ways to get oxygen for these children. And as I said, shunting is always from left to right, always in the heart. Now let's go over a little bit here. So we know that we have increased pulmonary blood flow when there's a hole between the left and the right side, right? I've already mentioned that because it's going to go back into the lungs. Now, in maternity, you heard about a patent ductus arteriosus. That's fetal circulation. All it does, it connects the lungs to the body. And it does that by the pulmonary artery to the aorta. And if you don't have oxygen, because of the way the heart was made, if we keep that vessel open, that child gets oxygen. So that's what I want you to remember. Oxygen going to the body. That ductus can do it, called a PDA. I go into more a little bit later. We've already talked about coarctation. Know that a stenosis is a narrowing. That means blood is still going a little bit through there. But an atresia means without. So a tricuspid atresia, no blood is going from the right atrium to the right ventricle. So that needs blood, oxygen, right? That one needs to keep that PDA open, right? We need oxygen going to the body. And then there's another one called transposition of the great arteries. And most of the exams love to talk about this one because you have the aorta on the pulmonic side and the pulmonary on the aortic side. So you have blood going around, and there nothing's getting to the lungs. There's no connection. So guess what you need? You need that little tube open to get oxygen to the body. And it works well. I mentioned the hypoplastic left heart, the worst of all of them. It's 3 stages surgery. That left ventricle, that engine of the heart, is thickened and it doesn't work. So blood doesn't pump. So just know it's a cyanotic. When we look at SEs, we look at NCLEXs. Tetralogy of Fallot, a cyanotic heart disease, is the most tested. And we're going to go over that a little more. So that duct, like I said, it's fetal circulation. It just connects oxygen to the body, all right? Now, when you're born, mommy keeps it open by stuff she produces, a hormone called prostaglandins. Mommy produces that. When mommy's gone and the baby's out, well, it's going to close. So how would we know it's open? How would we know it's closed? Well, when the baby's born, you're going to hear a washing machine sort of a murmur. They call it this washing machine sort of thing. The other thing, which is quite interesting, is something called a wide pulse pressure. Now, a normal blood pressure on a brand new infant is 60/40. That 40 is an 18 if we have that duct is open. That's the wide pulse pressure. And we can actually follow it when that number goes back to 40, that it's closed. Pretty neat stuff. So, patent ductus arteriosus. You want to keep it open, right? So to keep it open, you're going to have to give what mommy had, those prostaglandins. There is synthetic. It's a slow, continuous IV infusion, and it keeps open the oxygen to the body, the pulmonary artery to the aorta, okay? And what does prostaglandins do? It keeps cardiac output going, right? Because you got oxygen, body's happy, and the oxygen saturation levels are normal. Now, many premature infants are born, and it seems mostly premature. Sometimes, normal sized children, but many times premature, it doesn't close. So we have to do something to whatever or however they get that prostaglandins there. We need it to stop. We give something called indomethacin. Indomethacin is actually an NSAID, and it's given IV. And when we're giving it, we can hear the murmur close, and we can see the pulse pressure get closer to where it should be. And we know, oh, look, the indomethacin is working. I used to love watching stuff like that, but I'm a nerd. What can I tell you? They're showing you increased pulmonary blood flow. We've talked about it. It just shows you the way blood flows. There's some obstructions. Know that if it can't go down, it's got to go somewhere. And tetralogy of Fallot. Let me stop here for a second. Tetralogy of Fallot is all about the pulmonary valve, the pulmonary artery, which means blood that comes from the right ventricle that needs to go to the lungs and get oxygen. I had one TET spell in my career, and his name was Nolan Ryan. I'll never forget this little boy. And he had a TET spell at 4 o'clock in the morning, so I worked nights. And he had O2 saturations of 100. And all I was doing, I was wiping his mouth off, changing his diaper. I wasn't doing anything big. He did a TET spell. Now, what do I, as a nurse, what's my responsibility? Well, this kid went from 100 sats to 10 in a minute. He went from pink to black. It was incredible, the color change that occurred. So I took him and put his knees up and pull him up to his chest. So you put him on his back or on his side, and you put knees to the chest. What does that do? Well, you have your abdominal cavity and you have your thoracic cavity, and they both have pressure. And when you push it, it changes it and it pops whatever is holding that pulmonary artery closed, and it will open, and it works. So remember tautology and knee chest, very important. So congestive heart failure, you get a kid with a congenital heart defect, the heart's not beating right. You have a kid who has coarctation and the blood's not going, it's filling up lungs, right? And your heart's like going into failure. So how do we know all about this? Well, you're going to see the lungs fill up. You're going to see this child get tachypnic, right? You're going to see a weight gain because now they're keeping fluid because all this extra fluid is going to their lungs. So they've increased fluid. Look at them clinically, they're tachypnic, tachycardic, maybe retracting, nasal flaring, grunting, and you're like, what's happening? Put them on a weight, and oh my goodness, they've gained, 6 ounces or whatever it is, which is quite a bit for an infant overnight. So we want to make the heart beat better. We want to get rid of that fluid. So actually, in these children, if it's a congestive heart failure, we need to help this heart. We're going to give things like digoxin. And digoxin works very well on newborns. It does. And we're going to give furosemide, Lasix, which we work on adults too, right? So make the heart go slower, beat better, more efficiently, get rid of the fluids, and these kids turn around and do good. Remember digoxin and how to give it. Now, when you're an adult, they can tell you they're nauseous, right? Or they could tell you see yellow spots, which are some of the signs and symptoms, right? An infant can't tell you anything, can they? But you can see that their heart rate's too low, and you can see, did they vomit? And usually those two things is what clues a parent into something's going on at home. Even children who are just about ready for discharge, getting digoxin. So what do we need to do as a nurse prior to giving digoxin? Just like adults, count the apical pulse, check the potassium, check the last dig level, and is that child vomiting? What's the heart rate, right? We're going to look for those things. Hypoxemia, as I said, a lot of these children will suffer from low oxygen levels. And, you know, that hypoplastic heart, that child will never be a perfect O2 saturation. At birth, 75 to 85% is normal for them. And I'm not getting into all the reasons because it took me a while to figure that out, being a cardiac nurse. But when your body doesn't get enough oxygen for a period of time, what your body says is, let me produce more red blood cells. Because red blood cells has oxygen, right? And it carries it to the body. So the body keeps producing red blood cells, but there's no oxygen because that's the child. And that's called polycythemia. And that's why it happens. And that's a good picture of clubbing on a younger child. Now, cardiac kids are congenital. Cardiac kids will have this lifelong condition. Parents and children are going to have to take care of themselves. So from the beginning, and I'm going to tell you, cardiac parents, probably some of the nicest, sweetest people you'll ever meet. It always seemed that way, that, the nicest family has very sick cardiac children. And it's maybe because they're the ones that can take care of them well. I don't know. But it's just an observation that anybody who's ever worked in the cardiac ICU. Before I worked in the ER for the last 10 years, 15 years before that, I was in the cardiac ICU. So I opened the unit and watched it grow. And what I've learned is that from the moment that child walks in, you're teaching parents, they are thirsty. They want to know what's going on. They want to know what's going to happen. They want to be prepared so that they can do what they need for their children. So again, you're first, because it's a newborn, you are preparing the parent. As the kid gets older, you're preparing both of them. I already told you about cardiac cath, and we'll mention bacterial endocarditis. It happens to kids too. This is the one that there's an infection, a bacterial infection, and we know that we're going to treat that with high dose antibiotics, but they're going to be getting prophylaxis before procedures. Now, we talked a little bit about sore throats and mono, which is a viral. Well, let's talk about a strep throat that's bacterial, right? Streptococcus is a bacteria and it causes strep throat. Kids get it all the time, right? They share it. It's just part of what they do. Now, if a strep throat isn't treated completely or they don't get treated, it can cause rheumatic fever. Rheumatic fever presents with a sore throat, joints get swollen, rashing, could be some, mental, like the arms, you can't control your limbs. So it's, central nervous system, but it also can affect your heart valve, usually the mitral valve. Now, these kids come in and we determine, yes, they had a strep infection 3 weeks ago, or they had a sore throat. They didn't go to the doctor. They thought it went away. And what do? Treatment. Well, it's a strep infection. We're going to treat long-term antibiotics and everything, even the central nervous system, the joints will all go away, but the heart valve will never go away. Once it's damaged for life. Okay? But if we catch it quick enough, that's the key here. They can have high cholesterol, they can have Brady. I've actually seen an 18-month-old with a pacemaker. So, I mean, all ages get those too. Pulmonary artery hypertension. Now, you usually think of this as the older people where their lungs are getting tired and they're getting stiffened and oxygen and carbon dioxide don't get exchanged. I mean, these children, little exertion, are tired and they get chest pain because of it. And because it's related to oxygen, they get dizzy. I've actually seen children with infusions to try to help them dilate their lungs. I've actually seen Viagra used for pulmonary artery hypertension. And this was back in the early 2000s, right when Viagra was coming around. So it was like, what? But it does, it dilates, right? Cardiomyopathy, as I said, usually an infection. As I said, viral is one, but it could be, let's say, lupus, right? Lupus can affect the heart, so metabolic or collagen. Now, cardiomyopathies, we can tune them up. We can make the hearts beat good for a while, but it's still going to keep failing. Many times it gets to the point where they need a transplant. The biggest thing with transplant is rejection. Many students want to say infection. No, it is rejection what causes the heart to fail. We're talking about, cardiac, they're opening the chest. Many of them get chest tubes. Now, chest tubes themselves, they stick, they hurt, coughing, deep breathing, yes. But when they're removed from, taken out, they burn. Now, I've worked in adult and newborn open heart areas. So adults tell me when they pull those tubes, it burns really bad, but it's not forever. It's like 30 seconds and then it eases off. Make sure if we have children, whatever it is, you're going to do a painful procedure. Number one, let them know what's going to go on. Be honest. Tell them it's going to hurt a little, but I'm going to do everything I can to help you. And you're going to take their vital signs, medicate them for pain. And when they're done with the procedure, you're going to take vital signs again. When I first started in the ER, even 10 years ago, we didn't do blood pressures on kids younger than 5. And you know something? We found young kids having, hypertension. And what does high blood pressure cause? Renal disease, right? You've learned this in med surg. So we're doing more blood pressures than ever. Kawasaki disease is a viral. It is a where it's called a vascularitis, where the vessels get swollen and inflamed. And what we're concerned about is coronary artery aneurysms. Now, these kids usually come in with fever. You might see a rash, peeling palms of the hands and the soles of the feet, maybe even blistered. If you look, you see the lips all red and cracked, strawberry tongue. And I'm telling you, the biggest, brightest red eyes, they're almost glow in the dark. Now, it is viral, but you're worried about the vessels and the heart. So, how do we treat this? I think those pictures are great, and I love the strawberry tongue there. So we have an inflammation in the vessels. So this is the child we're going to give aspirin to, high dose aspirin. But why aspirin? It's used as your anticoagulant, right? Or we might be giving them an anticoagulant like Coumadin. Physician choice, mostly it's aspirin, and then to treat the virus, IVIG, intravenous immunoglobulins, because that boosts that immune system. So COVID, we know again, it can affect everything. So again, treatment, if it's attacking the heart, we're going to treat it like Kawasaki, okay? Shock. Kids go in shock. Septic shock is the first type that they go into. What does a kid look like? Elevated heart rate, decreased blood pressure, decreased capillary refill, decreased urinary output. You're all the things you see with an adult, you'll see with a child. Anaphylaxis, remember, if you're seeing anaphylaxis, making sure we have airway, and of course, we're going to get that epi in them, right? Septic shock, again, keeping the airway open, and again, treating the sepsis. Toxic shock, this is your adolescence. This is tampon use. So it's something that we need to teach our adolescents all about. So, question, here's that PDA thing. So if we closed that connection between the oxygen and the body, the pulmonary artery and the aorta, what would happen? So blood flows up the aorta, right? And it could go back into the lungs. So we're going to prevent that. We want all the oxygen to go to the body. So that's your answer. Any questions? A lot of stuff. This is a lot of different things. I've tried to simplify it for you, but I think your Cahoots will help you. Go into it again. Any questions about anything? Or are you just totally overwhelmed right now? All right, let's just get going. I'm going to go through as quick as I can for you guys. A majority of upper respiratory infections are caused by what? Kids get colds, right? What do they do from? Doctor sends you home all the time. It's a virus, Tylenol and Motrin, plenty of fluids, right? Treat symptomatically. You walk into a 6-year-old child's room and you find them not breathing and doesn't wake up. What do? Here's your CPR question. So you start chest compression. Okay, feel for pulse, start chest compression. And because you're in a hospital, you can call for help immediately. It used to be give breaths, but they found out many people wouldn't start CPR because they didn't want to put their lips in public. So they said there's enough oxygen in your body, just start CPR.
I have a question about that.
Okay, hold on a second. I'll get to you. Yes.
Okay.
What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? Kids are everything. Fever, vomiting, not eating is the big thing. What was your question, my dear?
So it said that they're not breathing. It didn't say anything about not having a pulse. So why would we start compressions on the off chance that they do have a pulse?
That was my question too.
No, I totally agree with you. And that's why I started out with the premise, if you do the pulse, they don't have one, you start chest compressions. If they do have a pulse, yes, you just administer the breaths, open the airway and administer the breaths. Absolutely, you're correct. You are correct. I need to reword that question. We'll throw that one out. Thanks. A multi. What do you look for when assessing pulmonary function? In pediatrics, just looking You can tell if a kid's in trouble. Ever see a kid between their clavicles? It pulls to the backbone, as I call it. Adults don't do that. All you do, pull their shirt down and go, oh, look at them. It's looking at the labored breathing, the depth, the ease of breathing, the rate, maybe. But I think when you're looking for, it's more of the other ones. We could include rate there too, right? Are they fast or are they slow? What would you look for after a child has a tonsillectomy? So remember, they're cut in the back of their throat and cauterized. Our big thing is bleeding, right? Children who post tonsillectomy that are bleeding, all of a sudden you're going to see them swallowing. That's why when they're waking up, I said you put them on their side just in case so they can bleed out instead of swallowing it and aspirating it. But usually a kid who is bleeding, you'll see them swallowing. Never put a tongue depressor down there. You can open the mouth and you'll see just blood on the tongue. That's all you need to see. I've actually seen a child bleed out post tonsillectomy. A multi. Nursing care for a child status post tonsillectomy include so tonsillectomies, they do hurt. Pain medicine, and it's, I'm telling you, acetaminophen works. Spicy food, absolutely not. Gum for the older people, for the ears, for the ear pain, and the ice bag also. Younger kids don't like it, but older kids will. A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? So we've talked about pneumonias, we've talked about croup, talked about epiglottitis and bronchitis. It's one of those, and asthma. Which one? It's bronchitis. Now, asthma is not at night only, it's whenever, okay? And tracheobronchitis is another name for it. Tracheobronchitis, bronchitis is the same thing. Bronchiolitis is respiratory syncytial virus. A multi. What signs and symptoms would you see in a child with otitis media? Ear pain for sure. You can see those, sometimes the ear will rupture and you'll see purely an ear drainage. Of course, that loss of appetite. Not always do you have a fever with otitis media. Sometimes you do not. The monthly immunization for RSV is? And it's called Synagis or palvizumab, which is your biologic. Remember, monthly from winter to early spring, only for the first year. All of the following are signs of early respiratory distress in children, except. So, which one of those is late? Now, in respiratory distress, tachypnea, tachycardia, diaphoresis, restlessness, absolutely. When that child becomes bradycardic, they're about to code because the heart's giving out. A 4-year-old child's been taking meds for asthma and they're still wheezing. What information is important to ask about this? Why? What's some information you need to know? Many times you'll have parents with these MDIs and not know how to use that little spacer. So teaching them how to use it's very important. Never assume they know how, always show them. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? So you have an 8-month-old. Respiratory distress. What tells you that? Respiratory rate 25, 108 is fine. Pulse ox of 95 is perfect. Abdominal breathing, but pulse of 100, no, it'd be higher. That retracting, restlessness, tachypnea, tachycardia. Signs and symptoms of asthma include all except so if you remember asthma, it's air goes in fine, but it gets trapped. So you can't get it out. So it's a prolonged expiratory phase. You can't get it out. So it's swelling in there, right? So asthma is all expiratory, it gets stuck, and all the other ones are that inspiratory, it can't get in. Signs and symptoms of congenital heart disease include all except So remember, congenital heart disease, they usually need extra calories in their food. They need, shorter times to feed them, not to overtire them. Many of those things that can help them get the calories they need and not burn up too many calories. But they're always going to be the smaller kid. Their heart's working so hard. What should you not do to children diagnosed with croup epiglottitis? Or just had a tonsils removed. So never look and use a tongue depressor. I mean, if you're going to do it, just open their mouth slightly, especially with tonsils, just to see the blood. You never go in there because you're going to obstruct it more. What is the epiglottis? So it's that leaf-like structure that covers the larynx when you swallow so you don't choke. Yes, all the above. A multi. Treatment for infectious mononucleosis. So remember, infectious mononucleosis, it's the Epstein-Barr virus. You don't need antibiotics, right? It's all symptomatic. Tylenol, Motrin, rest, and please protect that belly, the belly. No contact sports. You don't want a ruptured spleen. When doing an admission on an infant with a low-grade fever and a loose cough, one information is important. So you're admitting an infant to your unit. How do you place this kid? What information do you need? You think you can just get a kid that has this and just put it in a room that looks good, and you've really got to be careful how you do it. Because remember, just because they have a cough, what if it's pertussis, right? You don't know. Immunization status, important. You want to know their temperature, their fevers, and of course medicine so we can administer it when they need it. What is cystic fibrosis? So cystic fibrosis is all about mucus, right? It's the lungs, it's the small intestines, and in men, it does in the vas deferens, so they can't have children. It's all about clogging of mucus. What is the greatest risk for an infant having a cardiac catheterization? So you get a kid back from cardiac cath. What is going to be your priority? We're always worried about that hemorrhage, okay? Dysrhythmias, no. Allergic reactions, no. None of that stuff. It's all about making sure they're not going to bleed out, and they can bleed out very quickly. How is cystic fibrosis identified? Well, I told you one of them that makes you suspect is no stool at birth, right? For the first 24 to 36 hours. It's called a meconium ileus. But when you say that, then how do you say, yes, definitely it is? And it's either they've had those screenings before, but usually it's a sweat test that they do when they see the symptoms of no stool. Another multi. What is included in the plan of care for a child with cystic fibrosis? I remember one family, they had 3 boys, and they had 3 boys with cystic fibrosis. And one of the boys was also a cardiac, severe cardiac. I can see them all lined up with their vests on getting chest CPT in the morning. Remember, it's aggressive chest physiotherapy. And remember, we do the therapy before they eat so they don't vomit. And we give that the bronchodilators. Absolutely high protein, high calorie, those enzymes with the meals. And as I said, give them as much sodium as they want. They are spewing it through their pores. Never low sodium, high sodium. What is the drug of choice for pharmacologic closure of a PDA? Now, you can do a surgical closure, and I've seen them done, but most of the time we're able to do it with a medicine. And we know that we're going to give indomethacin for that. What is not a feature of tetralogy of Fallot? I didn't go into all of them, so let's do it. It's all right-sided. So on the right side, you have a pulmonary valve that's narrowed. And when it closes, it stretches that right ventricle, right? And the aorta, there's sometimes called overriding aorta, and there is usually a hole between the right and left ventricle. Now, the one thing that's not is the left-sided, which is aortic. That's the left side of the heart, okay? So when you think of tetralogy, think right-sided. What medication would you hold on an infant that is vomiting and vital signs are 98, 88, 32? All of these drugs listed here can all be given to infants and young children. They are all adult drugs too. But again, we give it in milligrams, micrograms per kilogram. And when you're talking vomiting, and a low heart rate, that's digoxin. Why would a child with tetralogy of Fallot not gain weight at the normal rate? So when they don't have enough oxygen, they don't have energy, so they're not going to eat. They tired out, so they're not going to be as big. A multi. All are examples of cyanotic heart murmurs except remember I told you VSDs like the Downs children have, they're not acyanotic. Well, it goes for the same thing with an ASD. When you're talking narrowings, you're talking about atresia without openings. All of them are absolutely the tetralogy and the tricuspid. Blood's not going where it should. Aortic, it's still going out. It's okay. But ASD, VSDs, and PDAs are all your acyanotic. You're going to see tetralogy and tricuspid. Can you imagine there's no opening between the right atrium and the left atrium, left ventral, the right atrium and the right ventricle? Can you imagine? It's closed. So they have to do a lot of different things on that child. What is the most common cyanotic congenital heart defect? And it's the one I tell you that it's the most tested on too. And it's your tetralogy of Fallot. PDA is not cyanotic, okay? Tetralogy is hypoplast. Thank God it's not the most common. Nursing care following a cardiac catheterization. So this is all about looking at the dressing. You are not going to do anything to that extremity. You're going to keep it straight and flat. They're not out of bed for 24 hours, bed rest. A multi. Nursing education for the cardiac catheterization include all except. And we know they can't ambulate and they can't bend that extremity. Very good. Which information is most important when rheumatic fever is suspected? So the kid comes in having all these symptoms, the swollen joints, having, the rash, having the chorea. What would you want to know? What can tell you, I know what's happening here. So rheumatic fever and strep go hand in hand. So if they've had a sore throat, they don't know it was strep. A sore throat probably was strep, okay? How do we treat it? We give long-term antibiotics and everything goes away except for heart valve damage. Signs of shock in children include all of the following except. So it is hypotension, tachycardia, and the rest, right? That was a tricky one. Which of the following best describes the pathophysiology of Kawasaki disease? Remember, Kawasaki is a viral, it's a vascularitis, and of all the vessels we're concerned about, it is the coronary arteries. They usually order an echocardiogram as soon as they hit the floor because they want to make sure those coronary arteries are okay. Multi. A clinical manifestation of Kawasaki disease is, what would you see? And you're going to see everything. Korea happens to be which one? Your rheumatic fever, right? The rest are all Kawasaki. What's the treatment for Kawasaki disease? Remember, it's the vessels, they're inflamed, it's a viral condition. What is what we're going to need to fix this child? It's aspirin and IVIG. It's viral. Antibiotics do nothing. Which of the following is the most common cause of shock in infants and children? And it's infections. Overwhelming sepsis is what causes shock in children and infants. What are the defects associated with tetralogy of Fallot? I told you right side. Remember, it's the pulmonary artery that gets stenosed. It's that VSD, the aorta comes over and that right ventricle gets stretched. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell. You know, there are some older kids that don't have their tetralogy fixed for whatever reason. And they just all of a sudden do this, which is crazy. They squat and it does a knee chest without doing like an infant doing it themselves. And they squat and it helps them. Transposition of the great arteries is what? You know, when you have your blood flowing, systemic and pulmonic, and they're not together, what do you need? Well, you're going to need prostaglandins. You probably are going to have that hole made, that patent-foraminal valley between those, the atrium made bigger. We do a little balloon ball there, and then we do something called a switch. And it switches them, and they take the top and turn it around and put it on. But it is that prostaglandins, which gives them about a week before we have to do it. So which of the following is not an intervention indicated for transposition of the great arteries? So oral, nothing is going to work on this kid. It all has to be something a lot more drastic. Initially, it's getting those prostaglandins on, then doing the balloon atrial septostomy, waiting a week. These kids are in mother's arms feeding a bottle for the first week until they do the surgery. Gives them a little bit of time. A multi. Why is prostaglandins given to a child with transposition of the great arteries? What does it do? Remember, it opens oxygen to the body, right? It's your lifeline of oxygen. So it's two things, oxygenation and cardiac output. Very good. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? So it stops wherever that prostaglandin is, the prostaglandin has come from, right? It stops it. So it will close up that PDA, and then you don't have to do surgery. If you need to do surgery, they do a thoracotomy. They actually put a staple on it to close it. Where is the patent ductus arteriosus? Where does it connect the oxygen? From what to what? And it's the aorta to the pulmonary artery, okay? Think about it. Big aorta, big pulmonary artery, connects them. Lungs to the body. This heart defect allows blood to pass from the left ventricle to the right ventricle. It's called a ventricular septal defect. The septum is not completely flush, so the blood goes through from the left to the right side. A multi. What is a sign of digitoxicity in infants? Nausea, vomiting, and decreased heart rate. Yellow spots is the adults. An infant can't tell you they see yellow spots. At least most that I know. What is congestive heart failure? So we know the heart's not working right for whatever, whether it's a kink, whether it's the muscle, whatever, and the blood will just go up to the lungs and sit there and fill up. Very good. Left-sided congestive heart failure causes what? So all that left side is filling up. What do you see? Where does it go? The coarctation goes down. Shortness of breath, cough, fluid in the lungs. Very good. After a heart transplant, what's the leading reason children die? And it's rejection. Very good. A multi. Signs and symptoms of rheumatic fever. A little bit of all of them, right? And remember, they all go away. All you have to do is treat the strep, give antibiotics long term, but the valve, it's going to be permanently damaged if it hit it. A multi. A child's about to have chest tubes removed. What should you do? So you're going to explain it to them that they understand it, medicate it for them, tell them it's going to hurt, but they're going to be sitting up semi-values. You're not going to have them just laying down flat. That burns and hurts more. A child just had abdominal surgery, cannot cough well enough to expectorate the secretions. What is your priority? I mean, they need to cough up those secretions. How are you going to get that done? I mean, basics of post-op care, turn, cough, deep, breathe. Well, they're not going to do any of that until you medicate them for pain. You just had surgery and you hurt and you can't cough. You're not going to cough getting them out of bed or moving them is going to hurt them more. Give them pain medicine and they will work with you. An infant of 3 months has a fever of 103.6. What would you medicate the infant with? And that is just your acetaminophen, no ibuprofen. A newborn infant is assessed and you find very weak lower extremities. What should you assess next? Remember I said you just have weak or no lower extremity pulses. How are you going to figure that out? That's your 4-extremity blood pressure. Lower extremities are going to have lower blood pressures and the upper are going to have higher because all the blood is up top. And you could say most likely it's coarctation, almost guaranteed. A multi. A critically ill child's on complete bed rest. What can a nurse do to prevent complications? We think of adults that are critically ill. We think them on complete bed rest, and you think about all the things you need to do. Children are the same, and you need to keep their lungs moving, keep them dry, use pillows and blankets. And of course, you can use those chucks. I use toys, I use blankets, I use all things to turn them, position them, and rub them if we need to. Elevate the head of the bed if we can. How can oxygen be delivered that's the easiest tolerated and accurately monitored for infants? And that's an oxy hood. It's a clear plastic cover. It's extremely accurate. Nothing's touching the face. The child can look around, suck on a pacifier, fingers, and it works great. Even the nasal cannula, they stick their fingers under it, and they can rip the tape off because that's what happens. A multi. What procedure is used to keep the lungs open with a child with cystic fibrosis? Deep breathing, coughing, chest CPT, not ambulating PRN, ambulating QID, not just when they want. And of course, exercise is always a part of that. Get their lungs moving. And again, swimming pools are great. Multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? Right before a meal, sprinkle it on the food. Never chew those little beads. If it's powder, have them rinse. And the one that we all forget is to increase the dose as they grow. They need bigger doses. What is a cardiac defect when there's no valve between the right atrium and the right ventricle? Well, what valve is there? Mitral, aortic, pulmonic, tricuspid. Which one? And its tricuspid valve is there. Again, go back and look at your anatomy. Last question. When an infant is breathing fast, tires easily, and needs rest periods during feedings, what should you assess? What's going on? What do you think? And that's probably going into congestive failure. Very good, guys. We made it. Number 3. Jen, good job, Jen. Number 2, Jen. Number 1, Ms. Moneypenny. Very good. And Kian and Katie. So we did a lot today, a lot of stuff in here. Don't get overwhelmed. I think that look at your handouts that I gave you. They're really good and can help you through it. And anybody who wants any special extra tutoring, just let me know. Anybody with any questions? I'll see you all next week. Remember, the reviews start next week, so I'll see you there. Take care, guys.